Hello, my name is Neel Anand, and I was going to talk to you today about how I indicate patients for circumferential, minimally invasive correction of adult spinal deformity. I mean, mainly with regard to the psoas approach, which is a big part of the approach itself. Like I always say, for any indication of surgery, I think there are three characteristics. One is the patient and what they want and what they're suffering from. Two is the physiological characteristics of the patient, medical comorbidities, and so on. And then three, which I think is really important, the anatomical characteristics of that patient's spine, and we'll come to that in a minute. When I talk about the patient characteristics and what they're complaining about and what they're actually want, I think it's really important we take due notice of that and not what we can do. Because we also need to realize, can this patient handle what we can do? I think that's a really important part to look at. And that many a time I tell patients that this surgery is not for you. The other is obviously physiological medical comorbidities. You have to assess that. See what medical comorbidities they have. Is that going to be a problem? Can they withstand what surgery we are doing, even though it is minimally invasive? The third is anatomic, which I think is really important. It's besides numbers and size of the deformity and how big the curve is and spinopelvic parameters, we know all that. Anatomy really matters because we're choosing anatomical corridors to access the spine. So the MRI is very useful in studying that. I would suggest look at the MRI carefully and look at different aspects of it. First is the bifurcation of the great vessels. And what we do, we access all the lumbar levels in the lumbar spine in a single lateral approach from L5S1 up. And all I'm looking for in the MRI is, can I access it lateral to the aorta, or do I have to access it in the bifurcation because the great vessels have already split? So if I'm accessing in the bifurcation, it would be an ALIF in the lateral approach. If I'm lateral to the aorta, it would be a pre-psoas lateral approach. It really is that simple, and each segment is then valued at its own value. So look at each segment separately, see what needs to be done. The CT scan, very critical. Look at each segment to make sure it's not fused. You may find a facet that fused. You may find some fusion into body that you did not see on MRI or X-ray. Clearly, we can't do a lateral approach at that level. So that changes what you do and how you calculate that around. Bone density, critical part of our protocol. If the bone density is low, it needs to be corrected. If it's T-score -2 or less, we would treat them with Forteo or any other parathyroid hormone analog and operate at the same time and continue that for a year. If it's 3.5 or below, I usually defer operating. Make sure they are on a parathyroid analog. See them again in 3 to 6 months so I know they're being treated, and then may consider doing it if they're truly symptomatic. So I hope this gives you some idea of how we indicate our patients. On X-ray, again, really important. If you cannot see the landmarks on an X-ray, it's all a whitewash. Suspect is highly osteoporotic, and remember, on table, all you see is an X-ray, and if we can't see landmarks, we really can't be operating to get the results we need. So in conclusion, I'd say, look at your patient, treat the patient, not the X-rays, and please assess if the patient can handle what we can do, for we can do a lot of good things, but the patient ultimately needs to succeed and feel the benefit of it. Thank you.